Sandeep has set up the stream. Okay,
I think it is already broadcasting and it's streaming as well.
Okay, so I'll just switch the broadcast mode, so then we'll have everybody joining in, the participants joining in.
Yeah.
Okay, great. Hi, welcome everyone. I was just waiting for just a few seconds to have everybody join in. Okay, so I'll get started. So thank you everyone for joining this third webinar in this series that we're organizing on strengthening healthcare and safety nets in the time of the COVID-19 pandemic. And before I hand it over to our moderator for today, I just wanted to mention a few housekeeping rules. So the chat is closed, but you can post any questions you have for the panelists in the Q&A box. And please feel free to upvote the questions that you'd like to see answered from other participants. And the moderator will sort of pick them up and ask our panelists to respond to those at the Q&A at the end of the presentations. And so just to get started, I'll introduce our moderator today, Priya. Priya is a senior program officer with the Bill and Melinda Gates Foundation at the India Country Office in their measurement, learning and evaluation team, where she leads a portfolio of research on health systems, strengthening and family planning with a focus on gender, social norms and equity. Prior to joining the foundation, she was the director of the Social and Economic Development Group for ICRW, Asia Regional Office in New Delhi. At ICRW, she led research, policy, and programmatic work on issues related to gender equality and poverty reduction, with a focus on the intersections between economic and health issues. Her expertise includes research, measurement, and evaluation of women's economic empowerment and access to health services, including reproductive and sexual health. She has expertise in programs for adults and girls empowerment, and was also the co-director of the ODI-led research consortium on gender and adolescence. She holds a PhD in health economics from Johns Hopkins, MIA from Columbia, and an MA and BA from the University of Delhi in economics. So with that, it's over to you, Priya. Thanks. Priya, you're on mute.
Welcome everybody. Thanks, Rishi. As Rishi said, this is the third in the series of webinar that JPAL is having under the auspices of a grant or an investment which is called CATCH, which is Cash Transfers for Child Health Initiative. CATCH has been investment which has supported several large evaluations and pilots to better understand and provide rigorous evidence on the design and delivery of conditional cash transfer programs and pay for performance programs in India. So in this series, JPAL has been presenting some of their ongoing work. And the way it's conceptualized is that we have some of the ongoing work of CATCH being presented here, but juxtapositioned with some of the other work that we think complements the perspectives that the CATCH research is bringing. So today we are actually focusing on some of the issues around delivery of cash transfer programs, like some of the challenges around delivery of programs and how some of the programs that rely a lot on performance of frontline workers, because there, as we know, as is evident even recently with the COVID work, that there was high relevance of social protection programs immediately in direct benefit benefits had to be transferred to families in distress that were vulnerable. And there were obviously all kinds of issues around tracking, identifying, targeting, and all kinds of information asymmetries in terms of who is eligible and who is actually getting the transfer, and whether on a timely basis, and whether they get the amount that they think they are eligible for, or whether they even know what they're eligible for. So a whole range of information asymmetries that get surfaced when you're thinking about both designing and implementing cash transfer programs. In the seminar today, we are actually going to discuss some of these challenges, which is going to be the first presentation is going to be an overview, very brief overview of the design challenges, followed by a pilot, a micro innovation pilot that Dr. Manoj Mohan is doing in Madhya Pradesh, that will describe how the pilot was designed to try and improve or address some of these on the ground challenges, or in implementation of cash transfer programs. And he's going to go a little bit more deep into the detail of the design. And unfortunately, due to COVID, they don't have results, but luckily for us, he'll also bring perspective from some of the other work that they've done in Uttar Pradesh to give a much more comprehensive understanding of what we are finding around performance issues in implementing some of these transfer programs and services to pregnant women. And then followed by a third presentation, which is kind of zooming out and not focusing so much on cash transfer programs, but really looking at performance issues broadly and bringing a larger perspective on how do we reconsider issues of performance, and whether cash transfers alone are or exclusively are an important instrument to address performance, or are there other alternative paradigms and perspectives. And then we'll open it up with a discussion to everybody. And so we have about, like, I would say 55 minutes of presentation between the three presenters. I would request you to please actively use the chat. We will not interrupt the three presentations. We'll just go in a flow, but we are making sure there's enough time for discussion. Our first presenter, and I'm just going to introduce all three of them, and then they'll go in quick succession. The first presenter is Sachi Bala, who works on the policy and strategic partnership team at the Bill and Melinda Gates Foundation. She leads the policy team's initiative focused on nutrition and gender. Prior to joining the foundation, Sachi has been working with Deloitte Consulting, where where she's been involved in strategic advisory assignments in the space of public health. She also has worked with the Center for Science and Environment on issues related to climate change and equitable development. She has done a secondary review of literature to really better, on behalf of the foundation's policy and evidence team, understand some of the design challenges with CCTs. So she's going to discuss that. We'll follow that with Manoj Mohan, who's an applied microeconomist focusing on health and development economics, and his background is also in medicine and public health. He's an associate professor at the Sanford School of Public Health at Duke, with secondary appointments in the Department of Economics and the Duke Global Health Institute. His research broadly has focused on topics such as health, healthcare in developing countries, looking at performance-based contracts, measurement of provider quality and performance, social franchising, and some of the work around social accountability and monitoring, which I think he will discuss today. Lastly is Tom Newton-Lewis, who leads the Oxford Policy Management's research on health systems strengthening in Bihar, India, funded by BMGF. Much of his work is focusing on understanding constraints in the performance of frontline workers and in identifying appropriate policy responses. Tom was also the country director of OPM's India office for 8 years. These are all three close colleagues, so I welcome them all. And without further ado, I request Sachi to please get started.
Thanks, Priya. I'll just share my screen, and hopefully you should be able to see my screen now. Thank you. I am going to just give a very quick background and then get very quickly into what is it that when we talk about child cash transfers for maternal and child health, what are the sort of pathways that we're looking at, and then move very quickly into what are some of the challenges that we see, both in terms of design as well as in terms of implementation. So just to sort of say, with COVID, we've seen a number of countries have introduced, adapted, or expanded their social protection programs. And a very large number of these have included cash transfers. For a long time, we have been looking at cash transfers, both unconditional and conditional cash transfers, and especially looking at what is the potential or what is their impact on maternal and child health and nutrition outcomes. I think it's important to call out why maternal and child health, because there are certain important considerations which won't apply to other cash transfer programs. One, I think timing is critical when you talk about maternal and child health. Uh, you are timing the intervention to the in utero period because that is really when the impact could be the most. Secondly, it is a moving cohort. There is always a new set of beneficiaries who need to be identified, who need to be registered, who need to be monitored, and need to be included in the program. And then lastly, there are implementation and design challenges which need ongoing resolution every time a new cohort enters the program. This work has benefited a lot because of experts that we have consulted across a range of organizations, from JPAL, UC Berkeley, IFPRI, from OPM, from Duke, from Ambedkar University. So it's a really large set of folks who have provided us inputs and have been looking at this issue. I thought it would help to just sort of say, give a little bit of background. What are the pathways that we're looking at when we look at improved? This diagram is specifically for improved child health. But what you see is that both for unconditional and conditional cash transfers, you are looking at increasing household income or cash in hand of families. And then there could be specific conditions which are looking at improving the utilization of health services, looking at improving school attendance. You are looking at the growth monitoring or nutrition, health and nutrition education. And the assumption or the theory of change sort of looks at how this will lead to an improvement in food security and food consumption, lower parental stress, look at how parents can provide better health and nutrition services to their children, how this could increase health-seeking behaviors, and ultimately lead to improved child health outcomes. We have seen that across various countries, low and middle income countries, that context plays a big role in the implementation, in the choice of unconditional or conditional cash transfers, and then design is critical. So we've seen that there are several positive impacts of cash transfers on health behaviors, specifically looking at antenatal care, looking at institutional deliveries, looking at immunization. There's also been positive impacts on reduced morbidity. We've seen in countries such as Mexico and Nepal that there have been improvements in cognitive and behavioral development, and especially where this cash transfer is being bundled with counseling or with parental support. In Latin American countries, we've also seen cash transfers leading to an increase in birth weight and height. But overall, we'd say that there is mixed evidence on health outcomes, on mortality, on stunting, on anemia. And I thought it would be helpful if we could sort of say where are the sort of potential barriers or where there are sort of fallouts that could happen, which don't allow the cash transfers to have the kind of intended benefit, as I shared in the slide before this. So at the time of cash transfers, there could be leakages. It could be that the right beneficiaries are not getting onboarded onto the program. It could be that the money is not reaching beneficiaries. It's not reaching beneficiaries on time. Secondly, there could be a gap after the families or the beneficiaries receive the cash. So there could be problems related to information asymmetry, nutrition information. household dynamics. So what is the role of women? What is the agency? What is the decision-making role that women have with cash that's coming in? And of course, there could be household preferences. And lastly, there could be challenges which are on the market side. So in terms of accessing both the system side and a public health system side, as well as the market side in terms of accessibility and in terms of availability and prices. Since we are talking about frontline workers, today specifically, I thought that while there are a number of considerations for design and implementation feasibility of cash transfers in India, I will not spend time talking about this generically or at a very high level, but really get into specific areas where we see that frontline workers are the critical stakeholders and are the ones who are going to be responsible for ensuring that these cash transfers have the kind of benefit that is intended. So first, looking at targeting and beneficiary identification, looking at what is the eligibility criteria, what is the documentation required, and the kind of reliance that is there on frontline workers to be able to register beneficiaries, to be able to share information with beneficiaries about what is the documentation required, what is the eligibility criteria. And I think there is a fair bit of evidence, and of course we can share this with our listeners later, around how frontline workers don't necessarily have complete information on what are the eligibility requirements. Is it that only one child per family can be enrolled into the program? What is the types of documents that are required? Secondly, looking at conditionalities. We've seen that both unconditional and conditional cash transfers are impactful, but it's also important to look at what is the preparedness of the system. What are the types and the number of conditionalities, and who is going to be looking and verifying whether those conditions are being met? Again, that falls on frontline workers. Sometimes the data is self-reported data. So what does that really mean for whether the conditions are being met or not being met? And then when conditions are tied to service delivery, such as, say, compliance to IFA tablets, what is the system? What is the health system? Is it really geared up to provide those services for the for the beneficiaries to be able to meet those conditions? Thirdly, looking at the role of frontline workers. What are the tasks? What is the trainings? What are the incentives that are being provided to frontline workers to be able to deliver on these cash transfer programs? I've already mentioned the tedious task often of onboarding beneficiaries, looking at the information that frontline workers themselves have. But what about the additional burden that frontline workers face in terms of paperwork, in terms of their capacity to provide services, and also sometimes financial burdens? So I'm sure Manoj will speak of this later, but there are financial burdens that frontline workers need to bear for their beneficiaries to really be able to access the program well. We've also seen the impact and the importance of information campaigns, of counseling, which actually leads to much higher impact. So specifically, let me take the example of Bangladesh, where we saw that more than 50 plus hours of really high quality counseling was the difference between programs which had an impact on anthropometric outcomes, on something like stunting, versus where there was just improvements in, say, child dietary diversity of a child's nutrition. And I know that I'm short on time, so I'll just quickly touch upon the burdens in terms of the monitoring, which again falls on frontline workers. Where there are digital MIS systems, are frontline workers really equipped with the kind of tools and the trainings to be able to use this? Where there are grievance redressal mechanisms, even where those are well set up, often beneficiaries reach out to frontline workers. That is the first point of contact. I think it's important to also consider whether that has an impact on how much beneficiaries trust frontline workers. If there is a delay at the level of the cash transfer reaching the families, do beneficiaries really sort of blame or lose trust in the frontline workers? let me stop there because I know we'll get into a lot more detail in the next couple of presentations. I just wanted to leave our readers with one slide where we've tried to capture what are the critical components for implementation. All of this is coming from research in India. We're still working on this. This is still, like I said, evidence is not necessarily complete in many respects. But I think there are certainly some areas that we know are there are directions that we must follow in terms of program eligibility and registration, looking at the design, the timing, the verification mechanisms that one looks at, looking at financial inclusion, especially for those who are the most vulnerable, the ones which are usually left out of the system. And then how does one get monitoring and grievance redressal mechanisms in place which are supportive of beneficiaries as well as of frontline workers who are really the first point of contact for many of these beneficiaries.
Great. Thanks a lot, Sachi. That was an excellent overview, and kind of really importantly positioning us for the conversation that follows, that the effectiveness of a program like a conditional cash transfer program um, does depend on the performance of a frontline worker and the inordinate burden on the frontline worker in order for the beneficiary to avail the benefit. Sometimes for which she is compensated adequately, or she may not be. And the whole element of trust that she's part of the social fabric. So if the beneficiary doesn't get the expected transfer, the person who actually may bear the brunt of it is the frontline worker, because she is the representative of the system in the community. And these are important issues that are going to come up later in the conversation. So over to you, Manoj, please take it from here.
Thank you so much, Priyan and Sachi. Your overview is fantastic. I think it fits in right with some of the material I was going to present. In fact, I wish I had your slides. It would have been a really useful sort of jumping off point for me. So this is work that, as Priya told us earlier, this is work that we've been doing in Madhya Pradesh on the PMMBY program. For those of you who are not aware of what that acronym stands for, it's the Pradhan Mantri Matru Vandana Yojana, which is the new maternal cash transfer program that the government launched a couple of years ago. We've been working with Niti Aayog and the state government in Madhya Pradesh on trying to help understand the program and also try to think about how you can help the government improve the implementation of the program and see if its effectiveness can be maximized or not. So what my plan for today, and I will try to keep my presentation brief because there's always a lot to present and there's only so much time. So what I'll try to compress in here is give you a brief background of what this program was, what this cash transfer program did. In the early stages of our project, we undertook a scoping study. We spent a long time trying to understand how this program is being implemented, what kinds of bottlenecks are there, and generate a little bit of evidence on some of the issues that Sachi mentioned as part of the theory of change. So funnily enough, most people who've thought about these issues can probably predict that this is where the pinch points might be. However, for policymakers to be willing to entertain the idea of introducing interventions there, sometimes it's useful for them to see the data as well. So the scoping study helped do a little bit of that, to sort of get data from the ground up, but also try to then develop interventions based on what we were seeing. So this is what I'll be telling you about, the awareness, enrollments, and payment stuff. Tell you a little bit about what we did with the experiment and the current status, which sadly is less than where we would have liked to be, and then switch gears to UP. This is work that we had been developing with Purnima Menon and her team at IFPRI. My colleagues Grant Miller, Alessandro Tarozzi, both of who are at JPAL, and Matt Boni, who many of you in the room know, Mantasha, who was here as well, and Rachel, I believe, is also signed in. So if you have any real technical questions, you should probably ask Rachel. I'll give you the big overview part of it. Okay. So PMMBY is, as I told you, a maternal cash transfer program. And the key objective of the program when the government launched it was to make sure that pregnant women receive cash when they need it. That is, when they are pregnant. And the objective of that cash transfer was so that women have money in hand so they can buy more nutritious food One. Second, reduce some amount of reliance on female labor supply around the time when they are pregnant so that they can take care of themselves. And in the process, improve maternal and child health outcomes because the payments were tied to three important parts of the process. One, they wanted to get the first payment out, the first transfer, the first tranche goes out when the pregnancy is registered. Second one is when the ANC visit is documented in the third trimester. It could be just one, but it has to be in the third trimester. And then the last one was when you have the full registration of immunization. This program, when it was conceptualized, was also designed to be distinct from what JS5 was doing, as well as what some of the state-run programs are doing. So several of you in the audience probably already know that Madhya Pradesh, as well as many other state governments, have layered on their own state programs to give money over and above all of this. Our research agenda in this case was then to say, well, if a state is going to implement this program, can we understand the demand and supply side bottlenecks and develop targeted interventions that can help improve the effectiveness of the program, and then evaluate whether these interventions and the program itself have an impact or not. So our research team over the years, initially, this is stuff I'm presenting right now is about the earlier scoping part of the work. We spent a lot of time collecting data from three sources in MP. We collected secondary data from the PMMVY over 9 months of its program implementation. A lot of primary data from household surveys. This is a small number of surveys, but it was targeted to be in specific districts where the program was being targeted, as well as interviews with the primary care providers, in this healthcare providers as well, to get more in-depth interviews. This whole operation happened between January of 2017 and March of 2019. And what we find essentially is looking at these key areas of bottlenecks. So mother gets pregnant, and the PMVY overview that you can see on the side, I've already told you, so I won't repeat. One important thing actually, design feature was originally when the program was proposed, it was supposed to cover 2 children, but over time, the state and the government realized they don't have enough money, so it was restricted to the first birth. So there's some serious problems around that. Mother gets pregnant, mother has to know about the program. So the awareness becomes important, otherwise then the enrollment in the program becomes a challenge. There are operational challenges in the enrollment as well. There could be some of the issues around engaging frontline workers, the collecting the documents, understanding the program goals are a challenge. Once all of this is set into place and the enrollee is enrolled in the program, do we have a system that can get the money out in time? If the money reaches the mother, does she know about the money at all? Is she able to access the money? Is she able to access the money in time and then do something useful with it? All of these are important considerations. And only after the money has been spent in a way that the program had designed it to be, which is spend it on nutritional outcomes, can you expect that the program can have impact? So if we think about, just this one little graphic that I think this was Matt's, my colleague Matt Booney, his creation. I like it a lot because it just shows us the distance we have to go from having a pregnant mother to all these things that need to be checked off, which sort of aligns really nicely with the theory of change that Sachi showed us on that slide as well, is exactly this idea that there's a lot that needs to be covered. So let me very quickly give you just some summary statistics that we found along the way. About 30% of eligible beneficiaries in this area in Madhya Pradesh were even aware of any maternal benefit program. And mind you, in this case, in MP, there's more than PMMVY. There's some very generous government programs as well. But the vast majority of people were not even aware of any of them. And only about 16% of the beneficiaries even knew about PMMVY. And among those who knew about the program, only about half of them reported that they were enrolled. Only about half of them could even remember that somebody had helped them enroll by filling out this form. So the awareness of the process involved was also very, very low. When we then said, all right, do you know if you received these payments? These are eligible beneficiaries who claim to have, some of them had been enrolled in the program. Very few of them reported having received the payment, and the amount of time between when the paperwork was submitted and then when they received the money was going to be very large. So in this case, about 45 days when we started. If you think about it, monies that needed to come to the mother in the first trimester, if it's going to show up 2 months, 3 months late, that is basically, the program is no longer going to be effective. So this time gap between processing the payments and the timeliness of the payment has to be really, really emphasized in this case. And some of these delays were because of excessive documentation. Like you were asking the same paperwork again and again. All of us have been through this. Sometimes there were issues around digitizing the payments where paperwork was collected and it would sit there for a long time and not being able to filed in. So we will try to get to these issues later as well. The last one I want to point out here is, even if a transfer is made, the average distance to a bank from the villages we were talking about is about 7 kilometers or so, right? And this is not an area where there's regular public transport. The mother cannot just decide, I'm going to take the metro and go over to the next bank. Oftentimes it's a matter of walking 7 kilometers, which is not even possible. Most of the families do not go to these banks in more than once every other month or so, which is again gets back to this whole point. We've transferred the money, but can they use the money or not? So overall, this is where we are at. The beneficiary awareness is pretty low. Related to that, program enrollment is very low. Only about half of the eligible beneficiaries said that they were able to recall filling out the forms. Payment efficiency has problems, and then the payment utilization is even lower. So if you look at the net impact of just the operational aspect of the program, there's a lot of bottlenecks along the way. So what we were trying to do to address these two bottlenecks, one which was the low awareness and the second, the enrollment bottleneck. The first one, seemingly very simple, a postcard intervention. But the elegance of the postcard intervention was three things. One, it was extremely low cost to create a postcard. Second is that the postcard can be tailored to a payment tranche. As long as you can get a postcard out to the mother, the minute the transfer has been initiated, she can know. She doesn't have to wait for 2 months to know that the money has reached the bank account. And then the most important thing, as I'll show you in a second, is it presents an opportunity for us to continuously remind the parents about the purpose of this fund transfer and how you can work with the nutrition department and other departments to get the information out. So our colleagues from IFPRI helped us design these, and I'll show you that in a second. On the enrollment bottleneck, we developed a Frontline worker app to minimize these data entry issues, but as it turns out, the state was also developing its own software in parallel, so we never went ahead with this in practice. And when our project was eventually put on hold, we were exploring partnerships with Digital Green as well as IFPRI to think about a model of community engagement so that we can involve not just the members of the family, but importantly, the spouses as well as other members of the community to help ensure that enrollment happens and then the benefits are targeted to the women as well. As I promised you, this is sort of what the postcards look like. So this is the first installment postcard. It basically says that, thank you so much for joining, yada, yada, yada. But the backside is where we get the opportunity to present contextual information that's relevant to that first payment. So we can say this is now that you've received the first payment, here's what you need to do for the next payment. You need to go get checked. You need to make sure that your cards have been filled out if you already had a baby or not. And then these are the kinds of nutritional foods. Same thing for the second one. We get slightly different information because now chances are the baby is about to be born. So then you give more information about the nutrition of the baby and the immunization and so on and so forth. So I'll skip through in interest of time and jump in. So this postcard intervention, we had been piloting it. We started doing that in October of 2019 and started working on it. And the first phase was completed by Jan of 2020. Over this period of time, around over 1,500 postcards we had mailed out. The good news was over 85% of them were actually received by the households. And then if you can see the blue line and the green line, the orange line here are quite important. The blue shows the amount of time it takes from the time when a payment was initiated to when the postcard was sent out. So these are just operational things. The department was not used to doing this. Originally, it was about 60, 70 days. And over time, they started narrowing this. They started learning that this can be done pretty quickly. We figured out some of the operational bottlenecks. Over time, it would take just about 10 days or so for them to be able to send out the postcards working in conjunction with the Department of Posts after the transfer has been sent out. And then it roughly takes about 8-9 days for the household to receive it after it's been transferred. So that's pretty good. And about 85-86% of households are receiving these cards. We've done some pilot work to try and understand if the mothers remember that they received it or not. Even when literacy was a problem, given the novelty, nobody uses post anymore. So the fact that the postman came with a piece of paper with your name on it became an event, and they would sort of remember this. So it had a lot of salience, and we were getting ready for the data collection. And also I should tell you, from the very small sample pilots that we were doing before we started data collection, we were hearing that already they were getting some pressure to the Anganwadi workers to help explain what was in there. And so this client-led demand for services was already happening. However, we had planned for our training and listing for the second intervention that we were planning, and the data collection for this around March 17th, 18th. And then, this was all BC, which is before COVID. So that came to pass. So where we are right now is we're back to the drawing board. We have been continuing engagement with the government of Madhya Pradesh. We know that the payments have resumed, but the access to funds, as you can imagine, was even more difficult during the COVID lockdown. So we are right now exploring whether we can repeat the postcard intervention. Chances that people will remember a card that came in January of this year is extremely low. So sadly, we might have to repeat that. But we are in discussion with our partners about these enrollment-related interventions as well. I'm nearly out of time, so I'll just take a couple of minutes to just tell you, when we think about the frontline workers working, there's this other project that Priya had also preempted about work we are doing on community-based accountability. And the simple idea here is we focus on delivery of services by frontline workers, ASHA, Anganwadi workers, and ANMs, and working with the village health sanitation committees and the VHND days, the days when these services are supposed to be provided. We developed interventions with the UP government to activate these committees, provide information on health outcomes as well as roles and responsibilities. So there was a very strong information component I'll show you in a second. And then in addition to that, you run the facilitation of these committee meetings. This was a randomized controlled experiment, which was run over a long period of time in UP. And we did the data collection 2 years after to look at long-term effects, 2-year-long effects on the program. This is information only versus all of that information combined with the facilitation, where a government appointed Gram Panchayat coordinator was hired and trained by the UP government to then go in and facilitate these meetings. We did this very deliberately to make sure we are not then accused of sort of being the academic who's running the program. This was very government developed, government run, government led type of an initiative. Overall, as you can see here, what we find, effects, there are effects, they're not large, gigantic effects. The biggest effects are on full immunization rates at the end of 2 years. And we find that facilitation plus information have slightly larger effects than information alone, although they are not necessarily statistically significant differences between the two. But overall, the point estimates are slightly larger, more significant when you have information along with the facilitation. This goes back to the point that both Sachi and Priya mentioned about the role of having very actionable, targeted information that's given to community, and that can help them engage and monitor delivery of frontline worker services. I think I'm out of time, so I should stop there and hand over to you guys.
Thanks, Manoj. I hope that there are questions in the chat. I would encourage people to start doing that now. And I think both Sachi and you have talked about, she mentioned the Bangladesh program, is that we are increasingly finding in that space of mixed evidence around cash transfer that information plus models really seem to be adding much more value, and information plus facilitation in this case. And here the facilitation has definitely something to do with the performance of the outreach workers or the frontline workers, because the facilitation is happening through village health and sanitation committees. So I think it's interesting that we while we are debating, the discussion really is on how to make conditional or cash transfers more effective. The bottom line is really something to do with the performance of the frontline worker. And both in terms of additional responsibilities, but additional clarity for her in terms of her role and conviction as to why she is an important conduit of the program, the benefit for the pregnant women. And I think that is interesting. Now, Tom has, through the research that OPM has been doing in Bihar, his team and he have been thinking a lot about these issues of performance. And it's a different perspective. I think I would like you to take it from here, Tom, and then I'd like that we can actually have a debate or discussion later in the discussion time. So please go ahead.
Great, thank you. Can you see my screen and hear me okay?
Yes.
Yeah, fantastic. So I'm going to talk a bit more generally about what it would take to improve the performance of community health workers. I'm going to talk specifically about the state of Bihar, but of course many of the issues are relevant for similar states. So just two things before I start. So firstly, as Priya has mentioned, we have quite a large team in OPM and a network of partners who work on this research, and I'm presenting on behalf of a reasonably large number of people. I'm sure some of whom are listening into the call. And secondly, a lot of our work is very strongly inspired by some of the recent global advances in thinking about community health workers. So I don't want to make unfair claims of originality about some of the work that we're going to present. So I'm sure everyone on the call is familiar with India's 3 cadres of community health workers. But just as a refresher, so we're talking about 2 different community workers at the village level, one representing the health department, an accredited social health activist or ASHA, and one representing the social welfare department, the Anganwadi worker. So an ASHA is not clinically trained. Her role is mainly focused on mobilization, behavioral change communication, and she's not a salaried worker, so she's only paid through incentives. An Anganwadi worker does a range of nutrition and early childhood care and development interventions, particularly running a preschool creche on weekdays, and she is a salaried employee. And above them, there's an outreach auxiliary nurse midwife, who's based in a sub-center, who comes to villages to deliver clinical interventions like immunization and antenatal care. So between these 3 cadres, they're expected to deliver the sort of basic, essential community-based primary healthcare interventions on a universal basis. So this data, it's a few years old, comes from the NFHS National Family Health Survey from 5 years ago. Things are obviously a bit better now, but what it shows very clearly is that actually quite a large proportion of women and children are entirely outside of the service delivery net. So they don't receive any services from these 3 cadres of workers. And there's an interrelationship back, I think, to some of what Manoj was saying around the enrollment challenges from relying on community health workers to enroll beneficiaries in cash transfers, when actually quite large proportions of the population fall outside of their net. So the interesting thing about this finding is that it's entirely consistent with 2 completely different interpretations, right? You can construct an argument or a narrative that says this low effective coverage is essentially the fault of the worker. You can equally create a narrative that says actually this low effective coverage is the fault of the system that the worker is based in. And this is going to be the focus of the presentation. And sort of deciding which of these problem diagnostics is closer to the truth is important, because which of these 2 you believe in leads to entirely different policy prescriptions that are actually mutually contradictory. So to set this up, we find it useful to go back to some quite sort of basic foundational management theory. So it's based on the work of McGregor quite some time ago. So talking about 2 different organizational situations. So in a theory X world, you have workers in an organization who are fundamentally disinterested in the work that you're asking them to do. And in order to get them to perform, you have to monitor and supervise them very closely and use a range of positive and negative levers to make sure that they are delivering. At the polar opposite, there's a theory Y world where you have staff who are intrinsically motivated by what you are asking them to do, and they will perform as long as they are enabled and empowered to do so. right? And we like linking back these two theories back to these two competing explanations of why there's such low coverage of the services that community health workers are mandated to deliver. Now, if you believe that this is a theory X type problem, that this is the fault of the worker, it leads to a policy prescription that needs a better and more intelligent use of incentives, plus also closer monitoring and supervision. If you believe that actually we're in a theory Y world, that the fault of this low effective coverage is due to the system, not due to lack of effort by the worker herself, then it leads to a different set of policy prescriptions. Essentially, you have to remove the barriers to performance that are facing the employee. I think what's interesting is that most public health researchers, especially in the last few years, would tend to believe, without unfairly romanticizing or idealizing community health workers, who would tend to believe that they exist closer to a theory Y world than a theory X world. Whereas if you look at the way that health systems actually manage community health workers, all of the management controls and systems around how community health workers are managed tend to assume that they live in a theory X world. These workers are subjected to extremely tight supervision and monitoring. There's a very large reliance on incentives to induce performance, particularly for ASHAs who are entirely paid through incentives. And if I was to be provocative, I would say that most economists, which I am one in theory, and I'm sure many of the people on the call are so used to thinking about the world as a set of principal-agent relationships that they tend to implicitly or subconsciously think of the world as a theory X type world. Whereas what I would argue in this presentation is we are closer to a theory Y type world, and the kind of solutions that come in a theory X type world are actually counterproductive. So in the work that we've been doing, we've been trying to explore, building upon this, what actually is constraining improvements in the effective coverage of some of these essential community-based primary healthcare interventions. And for this, we adapted a framework that's found in criminal justice. So in the criminal justice system, to prove that a criminal is guilty, you have to prove to a judge or a jury that the criminal, the accused, had the means to commit a crime, the motives to commit a crime, and the opportunity to commit a crime. So we quite like this framing. We've adapted it for the theory of performance. So a worker will perform if they have the means, the ability to perform, the motive to perform, and the opportunity to perform. We've done a bit of work trying to identify what are the subcategories of these three high-level categories. And we've used this as a diagnostic framework to try and look a bit more forensically at really what is stopping an improvement in the effective coverage, in Bihar at least, across cadres of some of these essential services. So just to summarize some of our findings at a high level. So first of all, starting with means, so looking at the ability of community health workers, particularly around their knowledge and skills. So we do find in many cases that this is a binding constraint on performance. The box plot on the left looks at basic knowledge scores of the different cadres of community health workers and one of the supervisory cadres. And we actually see that even with fairly basic knowledge questions, base levels of knowledge are fairly low, right, which is a constraint to delivery, particularly for services that have a relatively high informational content. So you can imagine ASHAs who are meant to do home visits to counsel mothers on danger signs of newborns, something that requires quite high levels of information. It's quite challenging for community health workers, for ASHAs, when their base levels of knowledge are low. So means are a problem. So moving on to motives, what we find across our research and synthesizing across different data sources is that there's no real evidence to suggest that the lack of coverage of these interventions is due to a lack of effort of community health workers, due to a lack of motivation. In fact, what we find is that most of these community health workers tend to work quite hard within quite challenging system constraints. And they do so because they are women from poor communities who have limited alternative livelihood options. So their families need them to keep their jobs. So it keeps them working quite hard to make sure that they retain their jobs. We see no evidence that these community health workers shirk and that that's the primary cause of low effective coverage. In some of our more deep work, we've been running statistical analysis, and we actually see no statistical relationship between motivation, effort, and performance, which for us reinforces our belief that the binding constraints of greater performance is not the effort and the motivation of the community health worker. So in fact, I think overall what we find strongly is it's mainly opportunity constraints at the system and institutional level that prevent community health workers from delivering more of the services that they are asked to do. So to give tangible examples of this, so in Bihar, there's a particularity that the material and financial resources given to Anganwadi workers to deliver take-home rations to pregnant women and mothers of children under 3 are based on outdated population norms rather than the actual number of eligible beneficiaries in a village. So what we find is that Anganwadi workers are only given less than half of the material and financial resources they would need if they were to give take-home rations to everyone in their community. Right? This directly stops them providing services to many. This has cascading effects. If you're not giving out food to beneficiaries, it's quite hard to persuade them to come and receive other services. And it puts the Anganwadi worker in an incredibly difficult position because she has to decide who gets what under this rationing. Other opportunity constraints include the chronic deficiencies in infrastructure and materials that are sort of fairly well known. Another type of example, we actually find this, the largest statistical predictor of whether ASHAs make home visits is whether or not they feel safe traveling around their communities. So these are all examples of opportunity level constraints that we argue in most cases are the binding constraints to improving the effective coverage of these essential services. These opportunity constraints have a direct effect through stopping them from delivering, but also an indirect effect through stopping community health workers from getting the respect and trust from their community members that they need in order to be able to perform. So putting this together, the sort of high level sort of synthesis argument from our research shows that there's no real basis to think that the lack of effective coverage is due to a lack of effort, it's due to a lack of motivation. In reality, it's primarily driven by a lack of opportunities due to system and institutional level constraints. And what we would argue is that investing more in interventions that actually try and force community health workers to deliver more, so either through tighter supervision and monitoring, accountability interventions, or through changes to how incentives are structured, are actually unlikely to deliver much additional performance unless you solve some of these system and institutional level bottlenecks, which are really preventing improved coverage. As we've progressed with this work and we've tried to think a little bit more about some of this opportunity level issues, we've started to frame the problem actually as one of empowerment. And this builds upon some of the recent global thinking on community health workers. So if you think about what community health workers do, a lot of it is actually about persuading people to do things, either to change their behaviors or to avail services. And to be able to persuade someone to do something, it requires them to trust you. So the performance of community health workers is very strongly based on whether they can develop strong trust-based relationships with their community members. One of the problems that we see is that the health system actually makes it incredibly difficult for community health workers to develop these trusted relationships because the health system itself treats them so disrespectfully. Right? Across cadres, CHWs receive very little pay, very late pay. They are subjected to a wide range of very punitive behavior by supervisors, lots of public blaming, naming and shaming, public admonishment. All of these things undermine their ability to build up the relationships they have in their communities. So some of the work that we've been doing, and I'll come on to, is started to think about what are the interventions that would actually start to raise the positionality and status of community health workers in their communities and in the health system as the basis for unlocking improved performance. I think the point at the bottom slide, just to reinforce the one I made on the previous slide, is it's also very important to make sure that when we do interventions on and with community health workers, that we don't further undermine their positionality and status within their communities and within the health system. So as I said, we've been starting to think about what some of the interventions might be that could empower community health workers to enable them to perform some of these theory Y type interventions. I'm only going to talk in detail about the last three, but just simply to say on the first one, I think we very strongly believe that shifting ASHAs away from only receiving incentives to getting a flat salary would go a long way to improving their status and how they are perceived in their communities, within the health system, and in their households. And a reliance on incentives is actually quite disempowering. I don't think there's any real credible evidence to suggest if you moved away from incentive-based payments to salary-based payments, that this would lead to a reduction in effort by these ASHs. So I'll talk in a bit more detail about these other three. So firstly, I've alluded to the fact that a lot of supervision, the behavior of supervisors that we see is very punitive and negative. But I think more broadly, when managing health workers, there are probably three elements that you would expect to see in supervision. There's a management aspect, but there's also an education aspect. A good supervisor would also try and build the knowledge and skills of community health workers. And there's a support aspect, trying to help community health workers overcome the problems that they are facing, particularly from the system level. But what we see in Bihar, and this is commonly documented all over the world, is that supervision actually tends to only focus on the management dimension, and that management is actually executed in an extremely negative way. So lots of focus on checking registers, auditing compliance, public blame, and admonishing. So very theory X style management controls. So we would argue that actually, because the community health workers tend to have fairly limited agency over their performance, that putting all of the blame onto them and not supporting them is actually counterproductive. So we know that there's a large reason why supervisors tend to act in punitive ways. It's a cultural norm. They're treated like that by their own managers. Actually, they have fairly limited agencies to solve the problems that the CHWs are facing. So they're trying to avoid showing that up by putting all of the blame onto the community health workers themselves. They tend to have very high caseloads, so it's hard to give each community health worker the time and effort that you need to do good supervision. But despite all of these underlying barriers, there's an emerging global evidence base that shows that actually giving training on supportive supervision techniques to supervisors combined with ongoing coaching and mentoring can actually start to change supervisory techniques away from this sort of counterproductive punitive styles into ones that are more supportive and more effective. We're actually starting 2 pilots on this, first in Bihar with the government of Bihar and in partnership with CARE, and secondly in the aspirational districts with the Pyramel Foundation, who've already been doing a lot of very interesting work on these issues. The second one that we're really interested in is around what it would take to shift training systems of CHWs away from an over focus on technical knowledge to also look at some softer transferable skills. So going back to this point that actually a lot of the skills that CHWs need in order to persuade people to do things are these kind of softer transferable skills: persuasion, communication, negotiation, influence, etc., etc. But at the moment, there's no real training on some of these softer skills throughout the system. So we've been trying to put some thought into what it would take to deliver good soft and transferable skill training at scale. And that's a very hard question, and I don't think we've been making a lot of progress on that. The last one that I will talk about is an intervention called PLA, Participatory Learning and Action. So this builds upon work pioneered by the NGO Ekjut in Jharkhand, who have been using ASHAs to act as community facilitators to bring communities together to reflect on the public health problems that face the communities, their causes, and their solutions. This has been a long-standing intervention that's being scaled up in various states, and there's very strong evidence based on it through Ekjut and their academic partners at UCL. There's a number of Lancet publications showing very strong reductions in neonatal mortality. But for us, the really interesting thing is about how it repositions ASHAs within the community. By using an ASHA as a community facilitator, it changes her positionality, her status, and to an extent achieve some of this empowerment that we've been talking about. And we are setting up a pilot on this in Bihar with Ekjut, which is also slightly on hold due to COVID. So these are 3 interventions that we're very excited about, a sort of class of interventions that may start to make progress towards these kind of theory Y interventions that actually empower and enable community health workers to perform and try and move away from some of these theory X interventions that we don't think are based on an appropriate problem diagnostic. So just to finish, just 1 minute to reflect a little bit on how the positionality of CHWs is changing during the time of COVID. So I think that what's been obvious over the last few months is how community health workers have been mobilized by the public health system to play a whole range of roles on COVID, including disseminating information, doing community surveillance, contact tracing, And a lot of the burden on adapting routine services to make them COVID secure has fallen on community health workers. I think on the right's a picture of a sort of tripartite group of community health workers doing a door-to-door survey in Bihar to identify symptomatic COVID cases. So this has really raised the profile in the discourse of community health workers. And to an extent, this has been matched by quite rapid policy reform. So the government at the central and state level has very quickly rolled out digital-based trainings to community health workers, launched a whole range of new incentive schemes, given them and their families health insurance coverage, lots of mechanisms for public facilitation, both through governance structures and also through the public health system. So these are all really great things that we've seen that actually reinforce and improve the status of community health workers, building upon the change role that they are playing during COVID. The flip side to that is these workers still remain the lowest tier in a very hierarchical system, and there are lots of very problematic things that remain about the way that they've been used during COVID. It's been well documented, some of the issues they've had in receiving adequate PPE, lots of issues in accessing normal incentives, not least because other services have been disrupted, a lack of investment in the psychosocial support that's so important during pandemics. A lot of them have faced stigma and difficulty at the community level based on their roles. So whilst there have been some very strong and positive policy changes, there are still lots of very negative and disturbing things that we've been seeing that all stem from this sort of underlying problem that there is a lack of empowerment and status of these workers. So I think what's important for us as a community of researchers and practitioners is to see how we can maybe leverage our work collectively to take advantage of this policy window that may have opened due to the increased focus on CHWs in the last few months, to drive through some of the larger structural and policy changes that would actually be the basis of improving the performance of community health workers. And there's lots of interventions going on. So Gates are funding an initiative called CoreNet, which is run by Quicksand, that's trying to convene researchers and practitioners working on COVID to inform the policy debate. One part of that is on community health workers, which OPM is convening. IFPRI have shown a very large amount of leadership. They're convening a large number of organizations to study and do policy advocacy on how community health workers are adapting their services to make them COVID secure. Centre for Policy Research have launched Pulse for Development in a similar kind of convening space. So there's a lot of organizations sort of stepping up and taking on leadership roles, and hopefully can collectively mobilize all of us working in these areas to take advantage of this policy window that's opened both through the sort of immediate changes in the roles of CHWs, but also as there's greater national, subnational and global focus on what it would take to make health systems more resilient and prepared for future pandemics. You know, I hope that collectively we are able to contribute to some of these debates and achieve some of this broader policy reform. I'll stop there. Thank you.
Thanks. Thank you so much, Tom. And you know, your presentation took us to current times where the whole issue of frontline workers or community health workers has really taken over public imagination. This was never an issue that would be of such high public, not just policy, but public discourse. So I think it's really important that we are discussing it today. And of course, this framing that you provide for us is really important, because for me, what it's allowing us to do is to really also start thinking about design of interventions from very instrumental to intentional to perhaps more transformative approaches. And I think each one has its place, but we can't imagine or expect transformative outcomes if our approach is instrumental. And I think that's really important here, because so much of the design of the conditional cash transfers or the cash transfer program relies on a very effective, robust, empowered community health workforce, But what we are learning increasingly, and through the work that OPM is doing, is actually a lot of the discourse and the thinking around training and capacity building from frontline workers has been dominated by theory X and not by theory Y, which is really much more recognizing system dependencies, empowering them, and removing barriers. So I think this is a really nice overview of all the gamut of issues around cash transfers at a very, very operational, real, at the delivery level. There are lots of questions, Manoj, for you around the design of your programs and what you've seen as success. I would suggest that we can respond to the specifics, like how many districts, did you find an effect on X and Y later. Instead, I'm going to actually perhaps focus on some of the bigger questions right now for you, and likewise for Tom, and then I'll probably raise a set of questions to all three of you. So I'm sorry, I'm just trying to get to the questions. This is difficult. Just a second. I think one question while I'm pulling up the list for you, Manoj, somebody asked an interesting question, whether if the benefit was designed around a miscarriage, like clearly it's around the first child, but if it was around the miscarriage, what could be the implication? If there was, does that count? Does a miscarriage count in this program, in the pregnancy maternal pregnancy program, and if it does, what might be the implications? As you think about that, I'll pull up the other questions.
So I know that it counts in the sort of accounting sense that if it's a child and as soon as the mother gets pregnant and she registers the first as soon as she goes in and registers the pregnancy, she is eligible for that first payment. And then if she makes it to the third trimester and gets the ANC done, she gets a second payment then as well. But then if it's a miscarriage, then no longer does she receive any payment after that, which is very unfortunate. Frankly, to the extent that miscarriages are not something that any parent ever wants or has control over, it's very unfortunate that then the receipt of any payments after that stops. But what the government then does is after that, the next time you have another pregnancy, the clock is supposed to start ticking after the second payment. So then once you get to the full pregnancy and you get your immunization of your eventual child that you get, then you're eligible for the third set of payments as well. So in some sense, from an accounting perspective, they view it as just a clock being on pause. There is a process from when the pregnancy occurs and then the live child is happening. If a live child doesn't happen along the way, then you start all again and then you go on. If we had better resources and if the program constraints didn't exist, I suspect they wouldn't have done that. I know that a lot of rather difficult decisions that the governments have made are basically about the budget. I mean, I know for a fact that even the initial decision of going from 2 children to 1 was a budgetary decision. But it's a bizarre decision if you think about the implication that it has. So I think the miscarriage is also one of that as well. It's a large amount. When the first budget was passed, it was almost about $12 billion. It was a massive amount of money. So
it's really interesting from a gender perspective. This question is so interesting. A previous evaluation that I had looked at on age of marriage, where a lot of the beneficiaries thought that the government was developing the incentive to pay for dowry. So in a way, it was reinforcing the notion of dowry, which was actually, there's a Dowry Prohibition Act in the country. And likewise here, there is a whole accent on the birth of a healthy baby, but the compromise and the opportunity cost for the woman through pregnancy may not be given adequate space.
Yeah.
I think there are some questions for you around whether how are people using the cash when they get it? Do you have any qualitative research that you've done around that?
Not so much. So initially, because of the fact that very few people were eventually getting the cash in time, so we didn't have enough data to the extent that the self-selected people were able to receive it in time and knew about it. They did say they were using it for food and nutrition, but it's such a leading question. I would not trust the piloting data that we collected to answer that question. It would have been nicer if we could have sort of got better data. So I don't have better response.
Sachi, in the reviews that you and Deva and others at JPAL did that you presented, do you have a sense of, are the incentives typically the benefits that are they used purposefully towards the behavior that we are trying to change? Do we have any research that you've looked at?
We do Priya, and we can share more details or a paper on what the cash is used for. Very often we've seen the cash is really being used to improve household food security. uh, it doesn't necessarily translate into a child getting better dietary diversity. It does it, and depending on the timing of the transfer, one also needs to see whether a pregnant woman is being able to actually utilize the improved food security of a household. But I think the evidence is quite clear that it is being used for uh, what one would consider as good products. So food, it might, if it is conditioned upon attendance in school, there might be supplies for school which are being utilized. The cash is being utilized for that. So
So Manoj, there were also questions around why is there low awareness of the program in Madhya Pradesh?
Why
What
is
did
there
you
low
find?
awareness? I think, and this is my slightly jaded opinion on this. I don't have facts to really justify them, but the launch of the program and its sort of dissemination of the process and the benefits was done through political speeches. So consider not only the central program, but even the state-run program, because the state program was launched a few months after the central program was launched. It was during the election season. So unless someone was paying attention to the then chief minister's election speeches about what they want to do for the mothers and sisters of Madhya Pradesh, you would miss that whole thing. Same thing for the national programs. It becomes a big deal when it's launched and then the national media talks about it. But then that information about what needs to be done, what are the eligibility criteria, was not eventually translated down. In our data, among the relatively few people who knew something about it, they learned about it from the Anganwadi workers. So there was no direct way for the household to learn. It had to be, we know already that there are all these impediments in who gets to the Anganwadi worker in the first place. So all those people who weren't getting in weren't able to get that information. So I do think that it's a matter of that chain, their entire chain not being able to pass that information through. It's also possible that these things take time. And I think that's actually a generous interpretation, that these things take time. So just give it a few more years, maybe things will change. But I'm not sure we have that much time to just wait it out on every program. We need a better system to get information out.
I mean, and there's obviously some correlation between financial inclusion, digital literacy,
Yes.
access to information. So actually, your programs are designed to reach the most vulnerable, but they are the ones who probably are media dark, digitally dark, and a range of other things. So it's almost high likelihood that they'll be the ones with the greatest disadvantage in access to information.
Yes. I recall the joint secretary, when the program was being designed, a month after the original announcement happened, sitting with him, and he was frustrated that so much of the advertising campaign in the first month that he was working on was based on Twitter. And he's like, doesn't make any sense at all, because the people who need the program are not going to see Twitter, which is exactly your point, is the digital divide gets in the way.
So can I ask you, it's not a question here, but I'm curious, when you designed the postcard, what was the hypothesis that people are more likely to flip the postcard and see the pictures, and there is going to be something very pictorial and graphic that is going to motivate a response, which otherwise was not possible?
Two parts to it. So one is exactly what you said. The pictorial aspect meant that it could help get over some literacy part. But the second part is, today, because people don't receive mail, most people don't receive mail like they used to back in the day. So now when a postman comes with something with a name written on, with your name written on it, saying this is something the government has sent you, even if you're not literate, you want to know what it is about. So that definitely helps. And in our experience working on other projects in UP and Bihar, where we tried cell phone-based approaches to try to reach out to mothers, there are so many text messages that come in these days that nobody pays attention. You almost either delete it or do not accept phone calls that come from random numbers. As a result of which, trying to reach people on cell phone to give information was not very helpful when we tried it out, which is why the postcard, at least, you have to physically, deliberately tear it apart and throw it away. It cannot be ignored because it's this nice bright piece of paper that's just arrived in the mail and sits there.
It's interesting. Stuti, sorry, Sachi, you were just mentioning some new work. Do you want to very quickly talk about it? Then I'll move to Tom.
Sure. So I think, Stuti Khemani at the World Bank has been doing a fair bit of work looking at the principal-agent relationship and how can frontline workers or public health messaging actually be improved by looking at a principal-agent relationship, and where do citizens fit in? Where do political actors, including those who actually have contested panchayat elections but not necessarily won, what is the role that they could play? Something that Stuti found for Bihar was that there are just a handful of newspapers that most people read. So, in terms of looking at what are the channels of information, it might be easier to target 2 or 3 newspapers, have a half-page ad advertising a specific government scheme, which would actually get many more eyeballs and discussion than something, advertising on television, like you said, Manoj, phone calls, who's picking up that phone, who's missing that phone call, who's reading an SMS. So that might be another sort of channel to explore more.
Tom, before I move to specific questions to you, you today shared a paper with me, which I found really interesting, which your colleague Madhumita Hebbar is a co-author of. Do you want to just say one line about that, and then we can move on to some questions? I thought that was really interesting about the dynamic data inclusion.
Yeah, I mean, I think Sachi alluded to it in her original presentation that this kind of cash transfer for pregnant women is inherently difficult because you need a continual enrollment system, right? You've got new women becoming pregnant all the time, and that is very complicated. So OPM's done a lot of work globally on the different approaches you can have to continual enrollment systems and different types of enrollment systems, which would be very happy to share on the group. But can I ask Manoj a question?
Go ahead.
Is that all right?
Yeah.
So PMMVY, so making it conditional, right?
Yeah.
Just massively increases the level of complexity, right? Both for communities, right? Because you're relying on the individual household to understand the conditionalities, understand the process for proving that they've met them, right? You're relying on them pushing up information to show that they should get the money, right? So it's asking a lot of understanding and agency of the household, and it's also asking an enormous amount of state capability to be able to manage and process that, right? And all the associated systems around dealing with errors, grievance redressal, et cetera, right? On systems that have extremely low levels of state capability. And by adding that in, you're losing all kinds of things, right? You're creating a barrier. Lots of people won't get the tranches. It leads to long delays, et cetera, right? So you're losing an enormous amount of the potential benefit from just giving sort of poor households money at the time when they need it, right? There's also quite a lot of evidence that shows that you can get similar gains to conditional cash transfers through unconditional cash transfers with some labeling, right? That if you tell people, here's the money, you're meant to use it for nutrition, they will use it for nutrition even if there's no formal condition applied. So it's a little bit like applying theory X to households, right? This layering on all this conditionality. But would you, if you were advising the Joint Secretary, would you not just say, just drop all this conditionality? It's just a faff. It's absolutely counterproductive. Just give the women 6,000 rupees instead and save everyone a lot of time and hassle.
Oh, absolutely. I fully agree with you. I couldn't have stated it better. In fact, early on, we tried very hard to convince the couple of states that were interested in trying to work with the program monitoring and evaluation, as well as partners from center, to say, if we're going to do this, can we at least like reserve some areas where we do unconditional transfers, exactly what you said, labeled unconditional transfers, because frankly, it's so much more efficient. Even if we don't change outcomes any at all, the outcomes are exactly the same. It's at least less of a headache to run it through. That alone is still worth doing. But the thing is, there just wasn't enough interest. And in a program like this, without having active participation from at least a state, it's not possible to run a conditional versus an unconditional transfer program for this. We could do it even now, but it's not going to be cheap to run because these are large programs, and it often got into permissions. The states were very cagey about trying to propose something that looked like it was going to go against the center. So there was a lot of the state versus center relationship as well. So in principle, I completely agree with you. I would love to find a state partner who is willing to entertain that idea seriously and try to do it. So yeah.
I think we have some state partners as attendees, so they're listening. They may seek you out. Okay, so Tom, we have 10 minutes and I will do one rapid fire for all of you in the end. So I'm directing some questions for you, Tom. I think people are curious about shifting from an X to a Y, or Mrs. X to Mrs. Y approach, or Miss X to Miss Y approach, and wanted to know whether this can be could you do this for lady supervisors at the state level, or does this have to be directed at the center? That was one question. And the other was institutionalizing an adequately paid role for ASHAs is really what will give teeth to this your entire argument actually about empowerment, right? Do you think there's political commitment for that? And do you think that in the absence of that, just building training and capacity in the absence of that would be effective? So 3 questions for you. I'll remind you in case you forget.
Okay, so the very quick responses. So the central government does technically have issued recently guidelines. There's a supported supervision manual, well, not that recently, which does cover a number of these concepts. And the Pyramel Foundation has been working very closely. I don't know if Dr. Shailendra is on the call, but with the centre and some of the state governments to operationalise these guidelines. So there is sort of, in theory, a sort of high level sort of legal framework or policy framework for this. If you go back to the sort of very original NHSRC guidelines, I think it was possibly 10 years old actually. A lot of it is called supportive supervision, but still when you look at it, it's still a lot of like monitoring formats, etc. So some of what Pyramel have been doing is updating some of those, and their work is very much, I saw another comment about, actually it's the problem above the supervisor, right? It's the block and the district levels behaviors you need to change first. So a lot of their work has been focused on sort of trying to change management behaviors and thinking about supervision at the block and the district level. And we are working with them to try and add in some piece at the supervisor level as they roll this out across the aspirational districts, but they're the sort of lead on this in India. On the ASHA salary, I mean, don't forget that there's a large number of states that either have shifted to ASHA salaries or some kind of more sensible hybrid with no noticeable drop-off in performance as a result, including some of the poorer states. So I think it is slightly a state-specific subject. I mean, I think one of the issues, it's a bit like with the cash transfers, but relying on incentive-based payments means that actually it's quite difficult to get a lot of money out, and some states that still just rely on incentives have extremely low expenditure rates of that ASHA incentive budget. So I think one of the northern states we were looking at, I mean, spends less than 50% of its ASHA incentive budget just because the systems aren't in place. So it's quite easy to shift to at least a hybrid, a salary plus the existing incentives without within existing state budgets, but lots of states have already got there. And on the training and capacity, is that aimed at lady supervisors, or is the question? Yeah, okay. So I think
can this be done at the state level? Can you move from an X to a Y approach at the state level without the center. That's the specific.
Yeah, I mean, look, the culture of some of these governments and organizations is naturally very theory X. So it is a bit of a behavioral shift. But this is not a problem that's common to Bihar or Northern India at all. And as I said in the presentation, there is an emerging evidence base that actually, if you give really good training, supported by ongoing coaching and mentoring to managers and leaders in a health system, you can actually help them sort of shift their leadership styles to things that are more supportive, more transformational. And a lot of people end up in management roles without any formal background in management, any training, and you know, there is actually quite a lot you can do just through providing that training, ideally supported by ongoing coaching and mentoring.
Okay. So this is, I'm going to have like I'm posing a question to each of you. I'm summarizing from what I'm picking up, but also some of my own. Sachi, to you, the question I'd like to pose is, are conditionalities problematic but necessary? And yes, no, explain. Very briefly, 1.5 minutes.
Thanks, Priya. I think the evidence is pretty clear that there is not that much of a difference between unconditional and conditional cash transfers. So I totally agree with what Tom and Manoj said earlier. Having unconditional cash transfers, but having counseling, labeling, having a strong system which is able to support you in being able to to be able to access services, I think is a better way to move forward. The point that Manoj
So was
made
the
earlier,
condition necessary?
I don't think
that is true.
No, I don't think conditions are necessary. I think having a supportive environment is necessary, though. And that supportive environment is information, is having the right sort of counselor, is having the right sort of frontline worker who can support you in accessing the system. And you need a strong system. So I think that is where I would say you put your energies and resources into. To Manoj's point about whether one can convince policymakers to explore unconditional cash transfers, I was wondering whether one sort of whether we sort of miss out on calculating what is the pressure on a system to be able to verify whether conditions are being met or not. Is there a sort of can we assign a monetary value to that, the time, the energy, the verification that goes in to whether beneficiaries are actually meeting those conditions, and the kind of impact that one could have when you're not able to verify that and you still provide the cash transfers, actually delinking the cash transfer and that behavior that you're trying to actually nudge towards. I think that's actually damaging. So maybe we need greater conversation around that aspect of how conditions can actually be damaging to.
Great, Sachi. Thank you. That was excellent. So Manoj, I'd like you to comment on performance or empowerment. What would you prefer if you had to design a more effective cash benefit program for pregnant women like the one you're evaluating?
I actually don't think we need to have one or the other. I know this sounds like I'm going to have my cake and eat it too, but I think a program, I think I'm just building off on what Tom had presented earlier. Is like, empowerment does not have to come at the expense of performance, or more importantly, performance does not have to be coming at the expense of empowerment. We need to be able to find solutions where our frontline workers feel empowered to do what they are expected to do. And as through that channel, we are able to do better. Right now, we are not doing enough of that. So I don't think it's one or the other, actually. And hope that's not too cagey.
No, it's good. It's all roads are pointing in one direction. I like that consistency. Tom, I mean, we clearly made a strong case for empowerment here, right? I think all the messages seem to be resonating there. But the big question is that increasingly there's more and more tasks being loaded onto frontline workers. I think there was a question around being roped into education, early childhood care and education. So given that, would you say that while empowerment is important, we also need to streamline roles, and we go back to systems of supportive supervision and leadership, and really shift accountability upstream.
Yes. So, I mean, if you think about Asha's, I mean, there are 39 different incentivized tasks, right, that they do, let alone all of the other unincentivized tasks. So clearly that's not a realistic workload. But it would also still be interesting to see what they could deliver if they were appropriately paid, resourced, and supported.
Okay, we are actually at the end. Urvashi is back. So over to you, Urvashi. I'd like to thank you for giving us an opportunity to talk about this really important issue. I'd like to thank all the panelists. I really enjoyed being part of this conversation. And we talked about our favorite topic, which is frontline workers, and how do we power them, and how do we respect and dignify them in all the work that they actually do for delivering very important services to women and our communities. Over to you, Urvashi.
Thank you so much, Priya, and thank you everyone for attending, and also to the panelists for your comments. I think there's just one point I wanted to mention, which a lot of you discussed, was about unconditional cash transfer. So if all of you have more questions about that, I'd really encourage you to check out the recording of our previous webinar, because a lot of those questions about the evidence on unconditional cash transfers was addressed there. And please do join us for the remaining 2 sessions in our series, where we'll be presenting some evidence on the impact of the COVID-19 lockdowns on agricultural households, as well as on healthcare utilization in Rajasthan. So a slightly different sort of track in terms of the evidence we'll be talking about, but I hope that will be interesting as well. And finally, please do fill out the feedback form. The link has been posted, because we love to hear what you thought. That's it. Thank you so much.
There were questions which were much more about information about the evaluations and the scheme, which I request Manoj to share with all the attendees. I mean, that's just very factual information that can be shared, including all the papers and the decks that were presented today. Thanks.
Thank you, everyone.
Bye.
Thank you.